Our immune system has billions of T cells. We could actually engage more or less all of them to be equipped with the BiTE modality. So here you see a BiTE-equipped T cell attacking a cancer cell. Through the presence of the BiTE technology, the T cell is capable of recognizing the tumor cell as an enemy and then destroying the cancer cell, attacking the next cancer cell, and so on and so forth.
Asciminib has been developed to specifically inhibit the myristoyl binding pocket of BCR-ABL, of the BCR-ABL protein. The myristoyl binding pocket is a very specific regulator of the activity of ABL, which is auto-inhibited in the normal ABL. In case of BCR, this auto-inhibition is lost, but can be substituted by asciminib. Thus, we have two options to inhibit BCR-ABL. One, the traditional option with tyrosine kinase inhibitors, inhibiting the ATP binding site, like imatinib, nilotinib, dasatinib, bosutinib, or the other way with asciminib, the myristoyl pocket, and allosteric inhibition of BCR-ABL. Asciminib had been tested in a phase 1 study, a dose-finding study in monotherapy and combination therapy. And based on the encouraging results of this study, a phase 3 study was conducted, the ASCEMBL study, which is reported here at this ASH meeting. And the ASCEMBL study met its primary endpoint, which was the major molecular response rate at 24 weeks after start of therapy. The major molecular response is significantly higher. The cohort of patients is larger than the cohort of patients achieving major molecular response with the comparator bosutinib. Asciminib is a very specific BCR-ABL inhibitor. That means it does not have off-target activity. And we assume that the main side effects of the other tyrosine kinase inhibitors are based on the off-target inhibition of alternative pathways, alternative targets. And that's not the case for asciminib. Therefore, we expected a better safety profile. And phase 1 has already shown a very good tolerability, but this has been proven in this phase 3 study here again. The major side effects of asciminib, if you call it side effects, are thrombocytopenia and neutropenia. But my interpretation is that these so-called side effects are just problems of third-line therapy. That means the heavily pretreated patients, CML patients, have a lack of normal hematopoiesis, and with a very active drug, this may result in cytopenias which were transient and could be resolved with dose reduction or dose interruption. The major side effects of the comparator bosutinib were, as expected, gastrointestinal side effects, but also manageable. But these were the typical problems which have been observed with bosutinib before. Yeah, so far we have only one STAMP inhibitor. Asciminib is the first-in-class STAMP inhibitor. Of course, we expect more, but I see these inhibitors, since they are BCR-ABL specific and CML at first-line diagnosis, at primary diagnosis, is BCR-ABL dependent. The proliferation is BCR-ABL dependent. I see it in the future more in earlier lines, but of course it's a very good salvage treatment in third line, and this ASCEMBL study has demonstrated that. but I expect even better efficacy in first-line treatment, and such studies are ongoing, combination studies with the ATP binding tyrosine kinase inhibitors, and also studies in monotherapy. And I'm looking forward to the results of these studies, seeing an even better and faster molecular response as we have demonstrated with the other ATP binding tyrosine kinase inhibitors.